Thank you all for being here for the Psychiatry Intern Bootcamp. Here we have Jacqueline and Nancy and Justin to teach everyone what they've learned so far and what knowledge they have to impart upon us. So go ahead and introduce yourselves.
Yeah, thanks everyone coming here on a Saturday afternoon. This is sort of just, very basic level for today. And, excited for you guys to just sort of expound on it when you guys start in a few months. Congratulations to everyone and getting into your programs. My name's Nancy. I'm one of the fourth-year residents at Zucker Hillside, one of the chief residents this year, and I'll be doing a CL Consult Liaison Fellowship at NYU next year. And then maybe Justin?
Hi everyone, I'm Justin. I'm a PGY2 going on 3 at Community Memorial Health System in Ventura, California.
Hi everyone, I'm Jacqueline. I am a PGY3 at Stony, and I'm fast tracking into a child and adolescent psych fellowship in a couple of months. So if you guys have any questions about that, feel free to reach out.
Okay, and then before we get started, we have an hour today. We're gonna go through our slides quickly and concisely, and then if you have any questions that come up during the presentation, just drop them in the chat and we'll save them till the end and we'll answer them all together to make sure we get through everything. And then thanks, Rihanna, for moderating and helping us out here. Appreciate it. All right. Oh, she put in some info there. Survey, please fill it out so that we know what to do better and differently for next time. Yeah, and then she has a couple other things there. For the topics today, we're going to go over psychiatry interview, common diagnoses, safety, mental status, psychopharm, PRNs, catatonia, delirium, and determining capacity. The list was kind of designed for like really just basics. If you, we didn't have this, or I personally didn't have this going into first year, and I still think that you will do great, but just to kind of get you familiar before you start, I polled our intern class and they felt like these were some of the really important things they wish they had known. All right.
Okay, so I'll cover the first 3 topics. By the way, I have no relevant disclosures or conflicts of interest. So I want to start off with the psych interview. So the first priority, first thing you know how to do when seeing a patient in any setting is trying to establish rapport and build that therapeutic alliance. Because without that, you can't really get much info. But once you get that, then a lot of it just kind of naturally flows and comes together. So starting off, if possible, try to provide them with a safe, comfortable, private environment to talk to them. I know this can't always happen in the emergency room, but for example, in the inpatient unit, try and go for that. Sit down with them, introduce yourself and who you are, the purpose of the interview today, just to kind of orient them to what you're going to sit down and talk to them about for that half hour or however long you're going to talk to them. See, what name do they go by, their first name or their surname, just to give them a sense that, having some kind of beginning to have some kind of autonomy in the conversation too. And if you have time, letting them know all your questions are voluntary, everything's confidential unless there's concerns for safety. And throughout the whole thing, just conveying that you genuinely empathize with them, hold them in positive regard, accept them for who they are. Basically, establishing rapport is about making them feel safe, respected, appreciated, and letting them know that they are there to be seen and understood. And then that should help diffuse anxiety, help the information flow through more smoothly. When going into the interview, try to keep in mind, like, disposition, where are they going to go from there? Like, let's say they're in the emergency room, and you got to think about, does this person need to be admitted to the inpatient psych unit? Can they be safely discharged to an outpatient level of care, or are they somewhere in between where you need to watch them for a couple more days, 24 to 72 hours, to collect more information, monitor their symptoms, monitor their response to medications. Different places have different names for this. My hospital, it's called the Crisis Stabilization Unit. Other people, it's called Extended Observation. But basically, it's a distinction of how much resources and staffing are involved, typically a lot less than the inpatient setting, and also the insurance reimbursement for it looks a lot different as well. So that should help you narrow down what kind of questions you need to ask. Because if you're like, say in the emergency room, you don't have to ask every single question because someone else is gonna be asking them those questions in the next step, whether they're inpatient or outpatient. So keeping that in mind should help you to stay efficient. So I've included the general format for the first, this is for when you're first meeting them for the first interview. Depending on where you're at, that kind of helps you guide what questions to ask. For example, if they're in the emergency room, you probably don't need to ask them if they smoke tobacco. That can kind of wait till later, for example. But starting off, chief complaint, HPI, what brings them in, including sort of a brief sort of ROS covering the major diagnoses that I'll go over in a bit, to help you kind of narrow down what is the main problem that is bringing them to you, so that you can figure out, you know, can they go home, or what's keeping them from going home? Will they need inpatient level of care, things like that. Past psych history, including past suicide attempts, hospitalizations, diagnoses, making sure to ask, you know, when did they receive this diagnosis? Who gave them that? Same thing with medications. What meds are they on? What have they been in the past? Who do they see outpatient? Medical history, especially anything that happens to the head injuries, brain tumors, CNS infections, allergies, because one of the few ways that we could kill people in psychiatry is by giving them something they're allergic to. So definitely cover that real quick. Current meds, especially, you know, how often are they taking them? When's the last time they took them? If they're on long-acting injectables, figuring out the dose frequency and the last date that they got it. Substance use, try to memorize, like have your own list that you memorize for what substances to ask them about, and just run through it. Family history, social history, and depending on where you're at, that kind of decides how thorough to be with the social history as well. And the social history can also help with your safety assessment, which I'll talk about later. So just some last thoughts on the interview and some other tips. So when sitting down with them, you know, you're going to collect a lot of information, but it helps to just for the first 2 minutes, just let them tell their story, let it naturally unravel for the first 2 minutes. If they start going off track or rambling, then you can kind of redirect them, or just so that you can get back on track, get the information you need. But if you interrupt them too quickly, then that might kind of disrupt the flow of information. Just kind of let things fall into place. As long as you have in mind what you need to know, then just let the conversation flow naturally. Ask open-ended questions. If they're like too psychotic or manic, then you can switch to more close-ended questions to help things move along. Paraphrasing what they say and saying it back to them can also help check that you understood what they said, or they can tell you, you know, what they actually mean. Trying to maintain an open posture, or at least mirror their own posture, to convey that you're interested, want to know more about them. And above all, try to figure out what is that one thing that they're most worried about, that is on their mind, and try to convey to them that you're trying to help them with that. Don't just tell them that you care about it, but really show through how you're talking to them that you're keeping in mind what's on their mind, so that they know that you're working with them and not just working on them. Right? So real quickly on common diagnoses. So this is stuff that you can cover in the ROS too. So psychosis, so these are the major psychotic symptoms. And for diagnosis of schizophrenia, you need at least one of the ones on the left side, and you need at least 2 symptoms for 6 months, and there's other criteria, but basically assessing for diagnosis or for psychosis. So delusions are false fixed beliefs that are not amenable to conflicting evidence against them. And there's different kinds of delusions that you can review in DSM, like grandiose, persecutory, ideas of reference, delusions of control. Hallucinations, these are perception-like experiences without external stimuli. So usually in schizophrenia, you'd see auditory hallucinations. You can also see visual hallucinations, although those can also occur in conditions with more organic etiology. There's also tactile, gustatory, and olfactory hallucinations, but those generally point to a more organic etiology. Then you got your disorganized thinking, speech, behavior, and also keep in mind that negative symptoms can also be symptoms of schizophrenia. When assessing for mania, so just to review the criteria, it's an elevated or expansive or irritable mood plus increased activity or energy for at least a week, plus at least 3 of the dig fast symptoms, or 4 if they're only irritable and not elevated and expansive. The way I try to memorize what dig fast stands for, so you can go through it without having to look it up during the interview. The way I remember the criteria is basically E plus 3 for a week. That's like a rhyme that I made for myself, just to memorize like how many symptoms and how long that they're present. Next slide. MDD, just a quick review of the criteria. So you need 5 symptoms for at least 2 weeks, and one of the symptoms has to be either has to include depression or anhedonia. And for this as well, memorize Psyche caps so you can go through it without having to look it up. Anxiety, well, there's all different types of anxiety, but real quick, GAD, excessive worry for 6 months that is difficult to control, plus 3 of the following: restlessness, fatigue, irritability, concentration, muscle tension, and sleep disturbance. A lot of these overlap with the depressive symptoms. So like the fatigue, depressed people can be irritable, have trouble concentrating and sleeping. So just remember that there's some overlap, and there's different kinds of anxiety as well. So there's, maybe they could get anxious in social situations, or maybe they're anxious because they're withdrawing from substances, or maybe they have some kind of phobia. So if you can, try to discern what makes them anxious, if it's not generalized, because that can help point you to something in terms of treatment and management. So next I want to talk about safety assessment. So there's no like calculator for calculating exact, percent risk that someone's going to hurt themselves or hurt others. So it's an art and a science. So you want to assess what is their risk of imminently being a danger to themselves or others, not just throughout their lifetime, but just, what's their acute risk. Mostly this is done in an emergency psych setting, but you're basically doing this at least on a subconscious level for all your patients. And it's incorporated into the psych interview. So as you're going through the psych interview, you're also kind of collecting data on what are their risk factors, protective factors. But if you're in the emergency room, don't go too in depth, because again, someone's, they're going to be telling 1 million people the same story over and over again. So at least for figuring out their dispo, just, all you got to do is figure out where they got to go. Are they at high risk of killing themselves or hurting others? And really trying to focus not just on like, do they have a plan? Do they have intent? Do they have access to the means? But also focusing on where is the root of that suffering that's causing the suicidality. And seeing how you can address where the suffering is coming from as best as you can. Don't place too much value on self-report. So just because they deny suicidal thoughts, that obviously doesn't rule out suicidality. It can help with the assessment. So it does count for something. But it, if they say they're suicidal or they deny that, it doesn't totally rule it in or rule it out. It's just one factor out of many. Keep in mind that chronic risk is not the same as acute risk. So if you got someone who's had, if their age, race, gender puts them at higher risk, if they've attempted suicide before, yeah, chronically over the course of their lifetime, they're at elevated risk of suicide, but also take into account other factors. Maybe they're not at elevated acute risk. Maybe they're stable right now. Or it could be vice versa, where they don't have a lot of the fixed risk factors, but they're in a lot of emotional distress and going through life stressors that maybe place them at more acute risk. So, admitting someone to the hospital, that would be for people who are at elevated acute risk. Whereas if that's low, then they could probably be managed in an outpatient level. Wherever you are, they're probably going to ask you, like, is this person at low risk or high risk? But I think what's more important is having a plan for mitigating the risk factors, strengthening the protective factors, and really documenting that well. Some red flags when you're talking to people, if they're not really cooperating with the interview, or if they have inappropriate affect, like let's say their dad just died, but they're like smiling and pretending everything is okay. That's kind of a warning sign. Or if you're asking, like, if you can call their family for collateral information and they're not letting you, that really limits your assessment and your ability to really ensure that they're safe. And try to ask everyone about access to firearms, because that is the #1 means of completed suicide, regardless of gender. I know sometimes in med school they'll say that, men shoot themselves and women overdose, but actually for both, the #1 means is firearms. So making sure that they don't have access to firearms, or at least trying to make a plan for removing access to that. So I want to quickly go over, I won't go through this entire slide, but basically think about it in terms of fixed risk factors, things you can't really change, modifiable, and protective factors. So I think different people say different things about the age that you have higher risk, but your program will teach you about, age groups that are at higher risk. Racial groups tend to be Caucasian, Native American, gender, marital status, whether they have prior attempts, history of trauma, medical illness, family history, and then think about the modifiable risk factors. So like, what symptoms are you seeing there right now? Are they suicidal? Are they depressed? Are they psychotic? What can you do about those? How can you treat those? What does their social situation look like? Housing, employment, healthcare, finances. Do you have a social worker who can help with all that? Do they have substances in their system? Are they withdrawing? Can you treat that, or can you direct them to resources for that? And then protective factors. One thing, if they have kids, that having kids in itself isn't a protective factor. They have to be responsible for those kids. If they are, that can reduce their risk of suicide. Belonging to a culture or religion that either prohibits or discourages suicide, that is protective if they actually adhere to those beliefs surrounding suicide. If they're just kind of casually religious but don't really believe in the same, what the religion teaches, then that doesn't really help. So thinking about the mechanism through which these increase or decrease risk. Next slide. Violence risk. So think about it the same way: fixed, modifiable, protective. They're a little different. For example, so for violence risk, in people who are psychotic, and have a substance use disorder, I believe having that combination, their risk of violence is about 17 times higher than the general population, is what I was taught. And then there's other mental illnesses that can increase risk as well, but that's a combination you want to watch out for and see if you can treat, as well as organic causes that can affect their executive functioning, borderline traits that can make them more impulsive, access to weapons, obviously. And again, thinking about the mechanism through which these affect the risk. So like if they're psychotic, they're hearing God telling them to kill people, and God is also telling them not to tell you that he's commanding them to do this, that's super high risk, especially because someone as powerful as God is commanding them to. So something else to think about. And also making sure they understand, if they're denying that they want to hurt others, making sure they understand what are the consequences if they do, whether they be moral or legal. Like, is it a bad thing to hurt others, or, you know, do they not want to go to jail? Those are important things as well. When you're in the inpatient setting, I mean, as psych residents, mental health care workers, we're at increased risk of being subject to violence in the inpatient setting. I've actually been assaulted before. That was last year. So making sure to really making sure you're safe and talking to the staff about taking necessary precautions. Some warning signs is someone's getting in your face, cussing at you, or yelling at others, especially if they have a history of hurting other people. You know, just play it safe, trust your gut. If something just doesn't feel right, just get out of there. You don't have to be polite about it, because really your number one job is not to get punched in the face and to stay alive, and so that you can come back to work and be well. So that's it for my section.
Thanks, Justin. All right, I'm gonna start with mental status. Justin, I really liked your list of all those different risk factors, because for a lot of us, when you are documenting safety assessment, you're gonna have to really list all those out in your notes. So going back to those slides and having a list of things to look out for, things to put in your note, is really helpful. So for mental status, a good mental status, my supervisor really impressed upon me, like, you should be able to look at a mental status and be able to pick out that patient sitting in a waiting room. And so there's like an acronym for it, aseptic, and we're gonna go over each one. You've got appearance and behavior, so things that you notice before you start talking to the patient. Appearance, level of consciousness, attitude and behavior is a little different. Attitude is how they relate to you, so cooperative, hostile, guarded. There's behavior. Very cool. Okay. Behavior like eye contact and gesturing. There's movement. Put an example on the right here of what it might look like when you're writing it up. People do it differently. You can have like paragraph form, or you do like bullets. You know, a lot of stuff that we're going to talk about here today, you might end up noticing that it's a little bit different when you get to your own program. Everybody does things differently, but general content is all there. So if somebody might just say like alert, appear stated age, what they're wearing, acute, non-acute distress, difficult to redirect, or inappropriate laughing. As we go through these examples, it's all the same person. So I'm curious if people can like figure out what this person's diagnosis is. Minimal agitation, regular gait, posturing, no tics, tremors, EPS. Speech. So what are the mechanical qualities? We're not talking about content or thought process that comes later, but the mechanical qualities of the speech. You've got the quantity, the rate, volume and tone, fluency, the latency. You might also notice in some places they mentioned rhythm. I put some examples of adjectives on the right so that you have a bank of things to use when you're trying to describe the patient's speech. That helps me a lot writing a little faster notes when we first started. So you might see that patient is also hyperverbal, fluent, pressured, but regular rhythm, regular volume, happy tone. This example I took, it says happy tone, but I don't know if I would put happy tone on here. That kind of talks to content. Maybe I would put like, you know, loud tone or something for that one. So aseptic, AS, now we're on E, emotion, the mood and affect. You might remember from rotation, mood is what the patient reports and affect is what you observe. This little diagram on the right, I hope can help us like differentiate between range and intensity. Something that the interns mentioned they had trouble with is like, what's the difference between blunted and constricted? So first thing is figure out what that quality is. And then if there's no affect, if you may not have met somebody like this before, but you meet like a very severely depressed patient, you'll notice that they have no affect. They don't even look sad. It's just like nothing is there. That's flat, like no quality, no range, no intensity. That would be flat. There's appropriate or not appropriate to content. Someone who laughs when they talk about someone who died, not appropriate to content. So then range. So you have fluctuations. So that's going between different, the frequency of going between different qualities of the affect. So range is basically, do they demonstrate a full range of different emotions? Going from happy, they show some happiness, and they have had moments of sadness. Maybe they laugh at a joke. You know, they have good range. The intensity is basically of that quality that they're demonstrating, how loud is the demonstration of that emotion. So then you have blunted, someone who doesn't really show much. There's normal, and then there's like a dramatic intensity. And then you have congruent or not congruent with what they say that they're feeling. So this person said that the mood is fantastic, affect is elevated. You notice it's inappropriate, it's very labile, and it is congruent with fantastic. Aseptic, P for perception. You've got illusions.
So sorry, I was still wondering, so what's the difference exactly between blunted and constricted again?
So constricted is more for range. Notice
okay.
here, yeah, so someone who is just someone who's only showing dysphoria and not like someone who's just showing sadness, you would say constricted. But if someone is showing, who's demonstrated over the past week, they have some happy moments and sad moments, they have some broad range in their affect. But if they've only been sad for the last week and they've only demonstrating sad emotion, I would say constricted. Blunted is more about the intensity and the volume of their affect. Good question. Sometimes you'll notice, I think the confusion is that we see the word restricted and constricted listed with blunted and flat, and I would separate those out. Perception, you've got illusions, which is misinterpreting external stimuli. Justin kind of alluded to this when he was talking about hallucinations. Hallucinations, it's not exactly external stimuli, it's internally produced stimuli. So you've got auditory, visual. He mentioned a couple others. For the auditory ones, you also want to ask if they're command. You've got command hallucinations for hurting yourself, killing yourself, not eating. So that's really important. It offers another level of severity to the symptom. Depersonalization and derealization. So this person has auditory hallucinations of God commanding her to go to California, denies visual. Piece of like little pearl here. When I usually see visual, I'm thinking there might be something organic going on. So besides like primary psychosis, maybe there's something medical to sift out. In any case, this person doesn't appear to be actively responding to internal stimuli. Okay, thought content. You've got overvalued. Sorry, actually on this one, there's a typo. I would take out this last part. My apologies, because they have auditory hallucinations. Thought content, I'll adjust it when we send it out. For thought content, you've got overvalued ideas, delusions. Sometimes residents ask about the difference between an overvalued idea versus a delusion. An overvalued idea, others share that belief. A delusion is usually not consistent with like a culture or the personality or their education. Ideas of reference, thought possession, either withdrawal, insertion, broadcasting. If something is ego dystonic or ego syntonic, it's good to know. So if it aligns with what they believe versus not. You also want to include here in your mental status write-up any suicidal, homicidal ideation, intent, and plan. So this patient has grandiose delusions elicited of being an angel on a mission, denies suicidal ideations, and denies homicidal ideations. For thought process, so aseptic, the T is for both content and process. How is the patient's organization and formulation of thought? So here we're not talking about content. It's kind of about it's more the flow. You've got linear and goal-directed, circumstantial, tangential, flight of ideas, word salad, intentionally listed in that way, going from something that is more worrisome for an anormal mental status. So linear is more of the normal, is the normal mental status there. You've got looking at the quantity. Do they have a lack of thoughts or they have a flooding of thoughts? How fast their thoughts are flowing. This patient has a flight of ideas, racing thoughts. Aseptic I for insight and judgment. Insight, here we're talking about if they're aware of their symptoms, their diagnosis, and their need for treatment. Words you might use are like poor, fair, and intact. Same words for judgment. So have they put themselves or other people in danger? How's their decision making? Someone who has had a suicidal attempt, we would say poor judgment. So insight judgment for this patient was poor. And then cognition, sometimes I go as far as just doing orientation. Sometimes might go as far as considering doing like an MMSE, trying to describe their memory, or maybe some of their abstract reasoning. So this patient was oriented ×3, but they had poor attention, short and long-term memory intact, and abstract reasoning intact. So this patient, this is in the interest of time, this was you want to guess to yourself for a second. This was a acute mania patient. All right. Psychopharm, truly just overview, more information on the slides. Maybe you can go back. I thought it would be helpful to just have things on the slide you can go back and refer to. We're going to go by the major diagnoses that Justin had listed. So for psychosis, generally, the landscape of antipsychotics is first gen versus second gen. First gen has dopamine antagonism, second gen, a lot of dopamine and serotonin. And then you've got, put the common ones on here. The first in each group are more of the high potency, thorazine and like clozaril, more of the low potency, meaning how much affinity they have to the dopamine receptors. That has a lot to do with their side effect profiles, which you see on the right here. This, you'll notice in some of the categories, EPS, which I listed, what that might look like here on the right. There's weight gain, increased prolactin levels, sedation. We actually sometimes leverage some of these side effects as part of their treatment. Obviously not EPS. We don't want anyone to have that. But like someone who's not eating or someone who's not sleeping well, not the prolactin one. So, and then, let me go to the next one. For mania, Common ones, not exhaustive. You've got lithium, you'll see prescribed. You want to be monitoring levels here. Something that we always tell our patients when they get discharged, like no NSAIDs, make sure you're drinking water because these things affect renal flow and increases lithium toxicity. Lithium toxicity, here are some of the symptoms you want to watch out for. You may see people using anticonvulsants, Depakote, which is great. I don't think there's been any studies head to head between lithium and Depakote, but there's a lot more side effects with Depakote, which makes it not a appealing medication for some. It's teratogenic, tend not to give it to women birth in like child rearing age, also on birth control and something like an IUD. You want to monitor some of these labs. You might give them an antipsychotic, especially if it's a severe manic episode, like something you might see in the inpatient unit. Lithium or Depakote with an antipsychotic. Here are some of the ones we might use. For MDD, you've got your, that's a teaser. You got your SSRIs, your SNRIs, and atypicals. Generally, we will pick the medication based on like the side effects or some of the, there are little things different from each one that helps us direct which one we want to try. Just quick example, like Lexapro, you can titrate quickly, so that might make you want to lean towards that one. Prozac has a really long half-life. Someone's really bad with taking their medications, we might go for that because if they forget it for a day, there's a lower risk for withdrawal. I listed a couple other like descriptors for some of the other meds. One thing that you have to tell your patients when you prescribe meds is the black box warning that shows up when they pick up their meds. There is very, very rare possibility of like suicidal thoughts and behaviors on antidepressants. Sometimes people freak out when they see this and they may not want to take it. You can have your script saying that it is something that doesn't happen often and mostly seen in like kind of adolescents and like young adults. And the risk of not treating your depression may be worse than the small risk of increased suicidal thoughts or behaviors. I have some icons here on the right because these are some of the common side effects. Side effects on antidepressants, mostly in the first 2 to 3 weeks. If you can counsel your patient well, they can expect those things and not discontinue their meds in the first few weeks of trialing. So that's like GI distress, weight gain, sexual dysfunction, amongst others. You've got your anxiety meds, first line treatment, antidepressants. But if anyone's met or, has had their own anxiety before, you know that those meds take a while. And if you're anxious right now, you need something to help. So we might prescribe also some anxiolytics, short-term benzos, and maybe some others if you are worried about dependence issues. All right, Jacqueline.
All right, so hi everyone. Just let me know if you need me to edit my audio because there is a concert happening outside of my house today. But we're going to be going over some high yield PRN medications that is going to be very important for you guys to know before you even start your floors or ED or consults. So I'm going to sort of open up this question to everyone and feel free to either say it out loud or type in the chat. But your patient starts yelling, get the hell out, I'm getting angry. You arrive on scene. What's the first thing you would do? And feel free to, type in answers. I'll go back. Okay. All right, in the interest of time, we can go to the next page. So the first thing is always de-escalate the situation. There's different interventions. There's different interventions to sort of diffuse the aggression without the need for medications, and that's good. So offering food, offering snacks. A lot of hospitals have a comfort cart that can have like games or snacks to help the patients feel more calm. A lot of it really comes down to, listening to what's going on. If it's safe, you can approach the patient in a very open manner and just ask what's going on. You want to use non-threatening body language, and you want to show that you're trying to understand what the patient is going through. Typically, we don't jump straight into medications when there is agitation. Typically, we want to see what's going on and what else we can do to help them. Maybe they'll take some, food, maybe they'll take some oral medications, maybe they just want to speak with someone. And sometimes you can figure out who is a behavioral health specialist or someone on the floor who has the best rapport with the patient so that it doesn't escalate further. So first things first is always try to see if you can de-escalate the situation without medications. The second thing I want to bring up is in our hospital, it's called the code M meaning needing more manpower. I would just confirm with your own hospitals and programs, what is the code that's appropriate? If a patient is escalating and there is threats of violence or aggression, what code are you calling and how do you call it? Every hospital is going to have different number systems. For us, you would pick up the phone and press 321. You want to just check and make sure you have all of those safety protocols reviewed before you start your rotations. So the next thing is prioritize your safety. Like what Justin said, you do not want to get punched anywhere on the face, on the body. You don't want to get charged at. And unfortunately, in the field that we're in, that is a possibility on the inpatient unit and in the emergency department as well. And when you're dealing with agitated patients, sometimes that can be a possibility. You want to make sure that you maintain some distance, that you have help if you need, whether that's security or another staff member, and that you if you are feeling unsafe, you remove yourself from the situation. And that could mean excusing yourself and telling the patient that you're going to come back. Or if you have to run, if the patient's charging at you, you should go somewhere that's safer. And that could be the nursing station or somewhere that's locked. PRN meds we're going to talk about in the next couple of slides. And I do want to just mention that if it gets to the point where the PRN meds are not working and you do have to sort of escalate the intervention level, that can lead to something called a physical hold, where staff members are holding a patient down, whether for medication or holding them from doing something more aggressive and destructive. And then there's different forms of restraints, which is I'm going to keep it pretty simple for today, but there are different forms of restraints that are used at different hospitals. So on the medical floor, if you are asked to help out with an agitation, the main thing is figuring out why are they agitated. And there could be medical issues like different glucose levels, electrolyte disturbances, Wernicke's. You want to check for substance use, intoxication, or withdrawal. And then if this is due to medications like steroids, anticholinergics, amphetamines, other substances. So always getting more information would be number one. Next slide. So I'm approaching this in a very, very high yield fashion. There are a lot of different, methods of PRN medications, some that may be more, inclined in terms of your own program, but what we typically do is 5 and 2. So 5 and 2 is 5 Haldol, 2 Ativan. 5, 2, 50 is essentially the same thing with an extra 50 of Benadryl. And then we also do 2 and 2, which is 2 Ativan and 2 Risperdal. Those are the main ones that we use. We do also give solo antipsychotic medications, which are in the chart. The main takeaway from this chart is that there are oral and IM agents. And the long story short is that you would like to offer oral agents first, but if a patient's very amped up, sometimes it means that you have to go the IM route. IM medications, intramuscular, will happen much faster. So it is a much faster acting. And you can see all the numbers on the side in terms of the typical dose and maximum dose, but some things to know is that Haldol, we can go up to 30 per day, and then Zyprexa, we typically go up to 20 milligrams per day. There's also some clinical trials that show that it's more effective for agitation patients to get a combination of an antipsychotic medication and a benzo, like Ativan, versus just an antipsychotic patient alone, versus just an antipsychotic medication alone. So the main thing from this chart is IM medications do act faster than oral medications. But if patients are willing to take the oral medication and calm down, then it's okay to go the oral route. Next. So things to do, and I know Justin echoed this earlier, but always check allergies before you order any medications. If the patient is allergic to Haldol and Zyprexa, you don't want to give the same medication that they're allergic to and then precipitate possible like anaphylaxis or something worse. So always check for allergies first. The second thing is when you do give the medications, you want to follow up with checking the vitals, doing a physical face-to-face and documenting everything from the scenario of what was happening, why they needed medications, and following up how they've been doing after the medication. Documentation is going to be your best friend, so you want to document that. I would check with your programs exactly what documentation looks like, because in my program, we have 3 specific notes we have to fill out for every physical hold or restraint. And you basically have to follow OMH policies to make sure that all your documentation is correct to justify the medication usage. You also want to get EKG. A lot of our antipsychotic medications do prolong QTC, and that can put you at a higher risk of arrhythmia. So you always want to get an EKG after giving multiple IMs or antipsychotics to a patient. And then the last thing is we always want to monitor for other medications the patient may already be on. So if they're already getting high doses of sedatives, hypnotics, opioids, you want to just make sure that they're not getting anything more that can depress them even further. And the rule of thumb is, if there's anything you take away from today's presentation, it's never give IM Ativan and IM Zyprexa together. This is a high risk for respiratory depression in a patient, and it can be pretty severe. The chart that I put on the right is worth, I think, screenshotting, or just knowing that different benzos have different potency. They basically have different levels of different times of peaking and how basically strong they could be. So just like looking at this, you can see that Xanax is technically stronger than Ativan. It will, happen much faster, and it peaks faster, and it's basically faster acting. Next slide. Lastly with this is, it's okay to take a pause and debrief the situation. So say there was a code, a patient was yelling, you were involved in that case, maybe someone got hurt or someone was, yelled at. It's okay to take the team to the side after everything is resolved and just sort of debrief what happened. This typically helps a little bit with not feeling so traumatized being on the floor, or better understanding what else can be done in the future if the same situation happens, whether that means going in and, assigning different roles to different people, or recognizing what else you can do if a patient were to be very aggressive, and having like a collaborative like care team approach. So it's okay to, take a pause and debrief the situation, and not just continue seeing patients after a code. Okay, so again, we're going to go very high yield because we are, a bit short on time. But catatonia is a syndrome of multiple etiologies, and there are multiple motor and behavioral characteristics to this. I'm not going to go over each one because there's many, but if you do want to go through each one on your own, there's a Rochester, if you go on Google and type in Rochester catatonia Bush-Francis scale, they basically broke it up into every characteristic, and there's an explanation along with a video that shows exactly what that looks like. And I would echo that it would be important to review all of this before you officially start your floors or any sort of consultation rotations, because this may come up in your programs. The main thing to look for with catatonia is malignant catatonia, which is characterized by dysautonomia. So basically your autonomic nervous system that controls all of your blood pressure, heart rate, things like that, that goes out of whack. And so you have a patient who has catatonia symptoms along with hyperthermia, tachycardia, diaphoresis, unstable blood pressure. They may be blue all over due to low blood oxygen. So you really want to watch out for this, because this could lead to coma or fatality in a patient. And this is going to be your best friend as well. This is the Bush-Francis Catatonia Rating Scale. MD Calc actually has this on their browser for free. So if you are going to be seeing a patient for an evaluation for the first time, it's good to have this, and you can actually click through what you're noticing, and it will give you a total point scale on the bottom. The higher the number, the more severe the more severe it is. And what you can do is you can actually do this Bush-Francis rating scale multiple times to see if the patient is improving or not improving. The treatment is, again, to simplify the process, you would do an Ativan trial to see if Ativan's helping with the patient. Sometimes you can give like 2 milligrams of Ativan and IV, and then you'll see the patient, talking better, or like being a little bit more awake and engaging with the staff members. The other things that you can do are essentially prepping for ECT, trying memantine or mantidine, trying an anti-epileptic medication, and trying an atypical antipsychotic. The last 2 are more 4th and 5th line, and I do have the specific doses on this chart as well. So if you want to try that, feel free to screenshot this and look this over.
All right, we're also gonna touch on delirium. So delirium, similar to the catatonia, it is altered mental status. It's not the cause of what is going on, but is a syndrome, set of symptoms. And so on the left here, I gave some examples of things you want to ask for during an interview. And all these things will be helpful in your treatment of this patient with delirium. On the right is the CAM assessment, also can be found in MD Calc, super helpful tool, both when you are on your medicine rotations during first year and also in psych. They have a lot of scales on that you can use. Really important is just the delirious patient has acute onset, emphasis on acute, fluctuating course, and inattention, and then either altered consciousness or disorganized thinking. There are, I want to point out, multiple types of delirium. Hypoactive gets mistaken for depression, and then hyperactive sometimes gets mistaken for primary psychosis, mania, or dementia. And then sometimes there's a little bit of both. So I would caution us to assume that someone just has depression and then not treat delirium, being mindful that potentially it could look like these different things might make you aware that it is something that needs to be treated. There's like a high percentage of people who do not get diagnosed with delirium and then miss out on getting treated. Here are some common causes, but not an exhaustive list. Essentially, it feels like anything could cause somebody to be delirious. Delirium can be deadly if it's not treated. First thing you want to do is make sure you've identified the cause and treat the cause. If someone is in DKA, like treat it. If someone's dehydrated, treat it. Withdrawing from substances, treat that. And then on the right, you see supportive measures. You want to try to focus on treating the cause and doing supportive measures. And then only if a patient is agitated, I will say that there's not clear consensus in the literature if someone needs pharmacotherapy like meds for delirium, if all delirious patients needs meds, but I think the community is moving towards, using meds only if a patient is agitated. So here's just like a screenshot of the flow chart that our hospital uses for acute delirium, oral meds on the left, IV meds on the right here. And then you want to monitor also, like Jacqueline said, QTC, monitor that EKG. A patient on the medical ICU floor, surgical floor, they are probably on a ton of other meds that can also prolong QTC. So think about that. It's like antibiotics can do that. You might consider Depakote. You want to try to avoid anticholinergics and benzos, although sometimes if their QTC is prolonged, I have seen sometimes people use benzos as well. And then capacity.
All right, so capacity consults are really important depending on your program as well. Some of you may have to do capacity consults as an intern in the psychiatric emergency department with the ED setting, or even with consults on the medical or surgical floors. So, any physicians, anyone who graduates from medical school can do a capacity assessment. Why are they paging psychiatrists all the time? It really comes down to their comfort. If they're comfortable with doing a capacity assessment, that's fine, and they can document it on their notes. A lot of the times that they, end up paging psychiatrists, it's for legal matters or if risk management is involved and they need a psychiatrist to essentially document in their notes whether or not a patient has capacity. The important thing, again, to know if you're able to take any information away from today is there's a difference between capacity versus competence. So capacity is a clinical term, and it's usually addressing a specific question. Does the patient have capacity to refuse this imaging and go home? So they're going to be basically refusing this specific imaging in preference of going home. So maybe like leaving AMA as well. It shouldn't be something very broad, like does the patient have capacity to do, to make this medical decision? We need to clarify that competence is actually a legal term. It's court determined, not physician determined. So if someone's asking you to do a competency evaluation, that's not something that we would do. Everyone is presumed to be competent until proven otherwise. And again, that's through the court system. No capacity if they cannot understand the information that's given to them, retain information long enough to make a decision and to maintain consistency in their decisions during the conversation. And they should be able to weigh up, what is happening, what are the risks and benefits of what they're choosing to do, and to continue expressing the choice that they want. You really want to see if they can engage and not just reiterate what you're saying. So some patients might just repeat exactly what you're saying. You're looking for someone who can engage and make a decision based on the risks and benefits and explain to you why they're choosing this. I want you guys to take a look at the right side. I'm not going to go over each one, but this is the APPLBAUM criteria, APPELBAUM. It's definitely worth having this if you're doing a capacity consult, capacity evaluation, to look exactly at these different pieces and to document that if you end up seeing a patient for that. This is what we use across the board for all of our residents, and I think it's really important that you guys have access to that. So it's under APPLBAUM criteria, or you can screenshot what this looks like. All right, so we have a Q&A section and it's 2:01 p.m. So we might be running over a few minutes.
Amazing. Thank you all so much for all of those tips and a brief overview. I think we got some really good questions. So I'm going to ask a few, and then if anyone needs to log out because of time constraints, they can. And just a reminder, there will be a survey sent out. If you fill it out, then you will receive a copy of the slides. And this is recorded, and official APAMSA members will have access to the recording.